all the learned audience, respected chairpersons, and all of my senior teachers and colleagues. Assalamu alaikum and very good evening. And I was the last speaker in the first IPDI session also, in the, before the COVID era. And I shall be talking on a story of a gentleman.
Be more close to the microphone, please.
It is not moving. It is a story of a 55 years old normotensive non-diabetic gentleman presented with a central chest pain for 4 hours in National Institute of Cardiovascular Disease in the COVID time, in the 14th February, in the Valentine day. And it was our scheduled cath lab was not on the day. And after clinical symptoms scenario, and we do the ECG. And the ECG showed acute ST elevation in lead 2-3 IVF. In the right side, it is the right sided lead, and posterior extension also. It is acute ST elevated MI inferior with posterior extension. We counseled the patient party for primary PCI. At that time, patient was in dilemma patient party. And due to COVID pandemic period, we need to go for RT, rapid antigen test and other tests. So we plan to go for thrombolysis option. And there are options. Primary PCI is the gold standard management, and we also go for thrombolytics, and we also plan for pharmacoinvasive in our perspective. So it is a class 1A recommendation. It is primary PCI, and class 1A if within PCI can be performed within 120 minutes from the STEMI diagnosis. So we plan to go for thrombolysis first after proper counseling, assessing any contraindication present or not, and measurement of the body weight. Tenekteplase was given 45 milligram IV bolus over 5 seconds along with low molecular heparin. We all know that it is Tenekteplase is superior than the, it is more fibrin specific and 93% success rate. But unfortunately, after giving Tenekteplase, patient having ongoing chest pain and no ST resolutions. And we plan for, it is our end of our office time. We go out from the hospital after 3 p.m. But due to the patient having ongoing chest pain, so it is our duty of a cardiologist to go for pharmacoinvasive PCI. We plan for rescue PCI of this patient. We took him to the cath lab. And what are the strategy? Rescue PCI, it is the emergent PCI performed as soon as possible in the case of failed thrombolytic treatment. And we go for angiogram. And in the left panel, we can see there is a significant lesion in the 80 to 90% in the distal part of the LCX. And left main is normal, and LAD is free of disease, and diagonals and other vessels is free of disease. On the right side, the vessel is a bit ectatic and visible thrombus. Visible thrombus with TIMI2 flow and slow flow also present. And there is a haziness in the distal part before the carina origin of the PDA-PLV. It looks like a lesion or haziness due to thrombus. So what can we do now? Should we go for conservative management, or thrombosuction, or stenting of the vessels? According to recommendation, in patient with ACS undergoing PCI, if there is no slow flow, it is class 2A recommendation, and routine thrombosuction having no benefits. So we give GB2B3 inhibitor, and thrombus is a bit low, but there is a haziness in the distal part of the RCA after guide extension. So we wet the vessels, and we wet the vessels, but haziness is still not clear that if it is a lesion or not. So whether we keep it conservatively or give the stenting. So we plan to go for IVUS. And IVUS shows us the lesion of the morphology of the lesions. And IVUS shows there is a vulnerable plaque along with thrombus in the distal part of the RCA before the origin of the PD and PLV. And this is the culprit lesion. It is a mixed density plaques. So we are sure there is a lesion. So we give a dilating stent there. at nominal pressure. 3 into 22 millimeter stent was deployed, and this is the result of the deployment of the stent. It's still TIMI2 flow. And post IVUS run shows good stent apposition, but a proximal part of the stent was a bit underexpanded. So we give a post dilation of the proximal part of the lesion, and this is the result of the post dilation. It is a simple case, but the main, this is the post PCI after next day, and the patient was symptom free, complaints good, sterilization was done. And according to the guidelines, what about the IVUS? According to the guideline, IVUS use is only recommended, should be considered in selected patient with optimized stent implantation in left main patient and complex PCI patients. And what about the in primary PCI, use of IVUS? Use of IVUS in STEMI patients, actual culprit lesion may be lumen compromising or could be located proximally or distally. And in some studies, it is showed that recently a study has been published in Journal of American Heart Association, which showed it is in STEMI patients, if we do the IVUS primary PCI, it gives a less number of culprit basin lesion revascularization. So my take-home message from this presentation is, and every time. This is the study I have. I wanted to show, and my take-home message: primary PCI is the best and is the guideline recommended management for the STEMI presented within the time. And pharmacoinvasive strategy should be. It is another option in our context. And invasive coronary angiogram, that is IVUS, sometimes is helpful to see the morphology of the lesion and lesion characteristics for the stenting in primary PCI patients. Thank you for your patience hearing. And I must acknowledge my team and my professor. Thank you.